Now I would like to invite
about hepatitis B. Test all adults, vaccinate all patients who are triple hepatitis B panel negative, and treat all hepatitis B patients who are HBV DNA positive. We're going to talk about how to move towards global hepatitis B elimination. My disclosures are at my website, which also has many resources that you can use in your education and clinical practice. Really would like to thank the VASLD for inviting me to this very important meeting. I hope to visit your country soon. WHO has established hepatitis elimination targets. I'd like you to look at the lower part of this with hepatitis B and C infections with a 90% reduction by 2030 and mortality a 65% reduction by 2030. We're only going to get to this point by increasing the number of individuals tested, screened, found, and linked to care, specifically treatment. 2 people die every minute from hepatitis B associated disease, whether it's cirrhosis related death or liver cancer related death. This is a societal crisis that parallels hepatitis C. 88% of all hepatitis B infections remain undiagnosed. Risk-based testing has failed. We need to move to testing all adults and all those under the age of 18 for hepatitis B if there is a specific risk. Why test everybody? Because risk-based testing has failed. Risk questions are stigmatizing, inaccurate, often not asked. So let's move to test everyone. Risk-based testing has failed. Testing in the triple panel includes hepatitis B surface antigen, core antibody, and surface antibody. Surface antigen equals infection if present, core antibody equals exposure, and surface antibody indicates immunity if core antibody is negative. There is no such thing as natural immunity. This is an oxymoron, similar to plastic glasses. Hepatitis B is not curable. Thus, core antibody indicates the persistence of cccDNA. Core antibody testing has a false positive rate of 2 per 1,000. So if you see core antibody in any setting, it does indicate some level of hepatitis B infection after exposure. Risk-based has failed as published, and this is in the CDC 2019 document. 2/3 of reported acute hepatitis B cases had missing risk data or reported no risk. Let's test all adults, all individuals under 18 based on risk. This 3-test panel is inexpensive at a cost of $28 US in the US. Incremental cost effectiveness is far below $50,000, which is considered a boundary for cost effectiveness, although some studies have identified $100,000 or $150,000 for quality of life saved as cost effective as well. This may even be cost savings in the right setting. Why vaccinate all who are hepatitis B triple panel negative? Because that's the standard of care. Vaccination is highly effective, safe, cost effective, and a main path to hepatitis B elimination. There's a diagram for people who have quoted that they've completed their hepatitis B vaccine series. Make sure people have a test for the triple panel in the chart. But if they document they've completed 2 doses of Heplisab or 3 doses of the hepatitis B standard vaccine series, including the new vaccine PBI, I would strongly recommend taking those people out, testing, and follow-up. If you're not sure about completing the vaccination, you can give them an additional dose of Heplisab B or repeat 1 or 2 doses, but you do not need to check titers in those patients. What about treatment? Why hasn't early treatment been universally adopted? Well, our guidelines are strongly evidence-based, only at the highest level of randomized controlled studies, some of which we may never have in our lifetime. But these studies, these data, these guidelines do not address stigma, they do not address quality of life, and they barely address infection. There's really no other infection that's life-threatening that we delay treatment. Tuberculosis, syphilis, HIV, hepatitis C as many examples. We need to move to a treat-all model with hepatitis B, in my opinion. Patient compliance can be enhanced if we don't use the word to lifelong therapy. We have many new therapies evolving today. We will have much higher rates of functional cure, which is S antigen loss, DNA negative, in less than 10 years. Our current therapeutics suppress virus and decrease the risk of death, transplant, progressive cirrhosis and end-stage liver disease, and liver cancer. They improve quality of life. By decreasing infectivity, you decrease stigma, and you decrease the risk of transmission to other individuals. The guidelines talk about these different phases, but we are changing our terminology. We also know that 40% of patients are in some type of gray zone without specific guidance from our guidelines or guidance recommendations on who to treat. We're going to talk more about this immune tolerant phase shortly. We know about the burden of disease, liver cancer, cirrhosis, liver failure, liver transplant, and death. This is extremely well modeled. We also know with risk-based testing, we have failed to test millions of individuals, and people who are at risk of progression have not been placed on treatment due to very extensive, detailed, confusing guidelines. Global impact of HCC is high. 6th most common type of cancer, 4th most common cause of cancer, death, and hepatitis B is a leading cause of HCC. By treatment with our oral therapies, which are very safe, very effective for viral suppression, we can decrease cancer risk by 70%. Any DNA positivity indicates a higher risk of liver cancer. We know that hepatitis B is carcinogenic. We're going to talk more about integration slowly. But if you have a group 1 carcinogen, and we know it's relevant and relative to viral DNA levels, why not treat all individuals who are DNA positive? Risk factors for HCC include replication, but there's interactions with aflatoxins, alcohol, smoking, and fatty liver. If you look across our different patient populations, 15% of our hepatitis B patients drink alcohol heavily, 30% have fatty liver, 15% use tobacco, and aflatoxin exposure is common in Southeastern Asia and also in Africa. Moving to simple treatment guidelines would enhance treatment engagement. I'm going to just talk a tiny bit about viral oncology. We're going to talk about integration shortly, but this X protein is also considered a viral oncoprotein. We are targeting the X protein and decreasing X protein with some of our newer interfering RNA agents. I see hope in this realm as well. What about Delta virus? Delta virus piggybacks on B. I know Delta is rare in Vietnam, but even at a prevalence of 0.5%, 5 out of 1,000 patients, or 1 out of 200, testing is inexpensive, and linking these patients to care is extremely important. We're moving forward with recommendations to test all surface antigen patients for Delta. As new Delta treatments emerge, we're even more encouraged about this testing option. A little bit more on inflammation and cancer risk, as well as other changes that take place due to HBV DNA integration. We decrease inflammation by suppressing ALT, by suppressing viral replication, and decreasing cancer risk directly as well as indirectly by changing integration models. Definition of early treatment, in my opinion, is any patient that's HBV DNA positive. There is no such thing as healthy hepatitis B or hepatitis B patients doing well. These patients have ongoing inflammation in spite of normal liver enzymes, and they have ongoing integration, especially the more positive or the more high the viral load. Because many patients fall outside treatment criteria, they don't get treated, but look at that liver cancer risk, even when they're outside treatment criteria. EASL 33%, ASLD criteria 46%, and the POSL criteria 64%. outside treatment criteria weren't treated developed HCC. HBV DNA level at any level is associated with an increased risk of cirrhosis and liver cancer. Untreated immunotolerant patients have a higher risk of progression than those active disease on treatment. Another piece in the puzzle. Immune-tolerant patients here are highlighted below. S antigen positive, E antigen positive, ALT normal. Relative risk, adjusted relative risk, 61 for HCC risk. Integration is part of the story. HBV DNA integrates into the hepatocyte chromosome, and in this integrant, it's only producing truncated S. I've not found data for X or other proteins coming off, although that may change with further research. This integration is an early event and very strong data to support that it drives carcinogenesis through chromosomal instability, insertional mutagenesis. These mutant HBV genes can express mutant HBV proteins and may promote carcinogenesis as well. Clonal expansion is part of this pathway, leading eventually in a subset of patients to severe genetic changes, changes in oncogene and suppressor gene expression. This can occur in E positive and E negative patients. In this E negative patient study, these hepatitis B localized in genes involved in carcinogenesis. Clonal expansion is documented here. In immune tolerant patients, this clonal expansion is part of that pre-cancer state. Number of integrants is an independent prognostic factor for HBV-related HCC. The higher the HBV DNA level, the longer HBV DNA is high, the larger the number of integrations. Conversely, suppressing, which I'll show you shortly, decreases integration and integration activity. This is that transcriptionally active viral integrations by on-treatment tenofovir. We're decreasing those viral integrants and their transcriptional activity. Transcriptional messaging produces proteins that we believe are oncogenic. More data on tenofovir decreasing transcriptionally active viral integrations in chronically infected HBV. 3 years of tenofovir, tenofovir added in a few patients, showing full changes in integration. Year 3, including dysregulated genes. Nucleotide treatment significantly reduced the extent of HBV DNA integration and clonal expansion. Nucleotide treatment reduces the risk of liver fibrosis in patients with minimally elevated ALT in the TORCH-B study. Left side is Ishak fibrosis stage, right side is Nodell inflammatory score. It doesn't reverse everybody because we have confounding issues such as obesity, metabolic syndrome, and alcohol use. This is very important data here, about a 70% reduction in risk of HCC development in treated patients. This is a treated US cohort. This is patients living with co-infection with HIV. We are now treating all HIV positive patients. Almost every combination contains tenofovir, TDF, or TAF compounds. HCC development was cut in half versus hepatitis B monoinfection, most of whom were not treated. A little bit more data on risk of HCC in these HBV patients with and without HIV co-infection. Minimum of a year of treatment, 6 months follow-up. Baseline characteristics are highlighted here. Relatively low number of patients with diabetes and smoking and alcohol use. A large number with hyperlipidemia, interestingly. On the far right is the adjusted and propensity score rated hazard ratio for HCC in the co-infected individuals at a 60% reduction. If you have a maintained virologic response versus low-level viremia, higher cancer risk, I use this information in my practice to say anybody who's DNA positive, even if they're on tenofovir, TDF, or TAF, or entecavir, I'm going to add a second agent to get them HBV DNA undetectable. Early treatment is aligned with the goals of WHO. Also, less stigma, less integration, better patient-reported outcomes, better quality of life, and less infectivity. Goals of therapy are in EASL practice guidelines listed here. Again, early treatment is consistent with sustained suppression, regression of fibrosis and cirrhosis, reducing transmission, decreasing and treating of extrahepatic manifestations, including a decreased quality of life. More on guidelines, but I'd like to simplify this to say, treat anybody HBV DNA positive. You simplify the guidelines, treatment engagement will enhance. Regular monitoring of these patients, even if they're on treatment, DNA negative, surveillance, especially for hepatocellular carcinoma, if they meet surveillance guidelines. A little bit more on guidelines here. DNA positive, irregardless of ALT, irregardless of age, regardless of family history, would simplify this markedly. I would like to move this slide to a recommendation to treat everybody DNA positive who has hepatitis B. A little bit more on treating all adults as soon as they are infected, as soon as they are detected. Challenges the status quo, but we have great data on stigma, patient-reported outcomes, infectivity, and this is cost-effective. Looking at a little bit more data, treatment becomes more cost-effective over time, especially as annual HCC risk increases. This looks at decompensated cirrhosis in green, HCC, annual HBV-related deaths, and the treat all model, markedly enhanced compared to BASE, which is guidelines-based. I'd like to thank your wonderful meeting and hosts for inviting me here today. And hopefully I'm going to lower barriers to treatment with you with this important information to test all, vaccinate all who are triple panel negative, and treat all who are HBV DNA positive.
Thank you, Professor Robert Gies, for your very excellent and informative presentation. Giáo sư Robert Gies thì là một người có rất nhiều công trình nghiên cứu chuyên sâu về viêm gan B và đặc biệt là rất gắn bó Việt Nam. Thì sau đây xin mời các chuyên gia. Sau đây trước hết xin trân trọng mời tiến sĩ Vũ Quốc Bình, một chuyên gia về truyền nhiễm đặt câu hỏi. I would like to invite Dr. Vũ Quốc
Anh Hải, mình hỏi trực tiếp giáo sư hay là mình ghi?
Hỏi trực tiếp được. Giáo sư đang vào online chứ hả? Bên Thu à? Okay. Please.
Okay, good evening, Professor Robert Gies. Thank you very much for your, I think it's a very interesting presentation. Thank you very much for your presentation during your late night in your countries. And the second one is, your presentation, I think, is a very good overview about HBV positive patient management. And from your presentation, we learn a lot, updated and new interesting information. And from my understanding, your presentation is very, with very strong point. That is, any HBV positive patient equal treatment. That means we don't need to care how about HBeAg situation, positive or negative. Don't care to HBV DNA level, or we don't need care to for the liver function, ALT, AST. If my understanding is right, let me have two questions. The first one is, do you have any good evidence-based study for the slogan, treatment any HBV positive patient? The second one is, do you think any difficulties using antivirus treatment when the patient, they have very low HBV DNA level, and they have liver function, AST and ALT not elevated, or they have HBeAg negative. Thank you very much again for your very interesting presentation, and let me have 2 questions. Thank you very much.
Xin chào quý vị. This is Dr. Gish answering these questions. I apologize for any echo. I would like to answer your question with really 4 parts. First off, we're changing the terminology that AST and ALT are not liver function tests, but are now called liver enzymes since they don't represent liver function. When you use the word LFTs, one would be thinking best about bilirubin, albumin, and coagulation. I think the data is compelling now that this DNA at any level is associated with risk of progression to cirrhosis or cancer, worsened quality of life, higher infectivity, and stigma. We have component studies that we need to put together to come up with this final recommendation to treat all adults. I showed you extensive information on suppression and decreased liver cancer risk. We have data in mother-to-child transmission that higher viral load has higher risk of transmission. We need more data in non-mother-to-child transmission infection settings, such as household infections, but we know these exist. We also know the strong association with DNA level and progression to cirrhosis, liver failure, transplant, and death. We have excellent outcome data, including liver transplant, where suppression of DNA is associated with better outcomes. So I think we have the data today, and I presented part of that during this presentation. The critique on low-level viremia might be a little bit stronger, but I did show you data that these patients with low-level viremia are still at risk of significant progression and risk of disease, including cirrhosis and cancer. I think the time is to act today and include the patient in the equation. Most guidelines are data-based, but don't take into account the stigma, infectivity, extrahepatic manifestations, and these are all important considerations when discussing treatment with your patients and colleagues. I think the time is to act now to move towards hepatitis B elimination, preparing for all the new medications that will be evolving in the next 5 to
Hello.
Thank you for that great question. Thank you for that great question.
Any question more? Phó giáo sư Phạm Thị Thu Thủy có bổ sung thêm không? Cô Thủy ngồi đâu nhỉ?
Alo.
Vâng, mời cô Thủy.
Em không biết là hồi nãy giáo sư trả lời vậy quý vị có hiểu đầy đủ. Thì em hiểu thì giáo sư nói rằng cái men gan ALT, AST đó, thì nó là cái enzyme để biểu hiện có cái sự viêm của tế bào gan chứ nó không phải là chức năng gan. Thành ra nhiều khi chúng ta, người bác sĩ chúng ta hay lầm lẫn đó là chức năng gan. Về vấn đề là giáo sư khuyên là điều trị hết tất cả những người có ADN dương tính là tại vì hồi nãy giáo sư có trình bày cái vấn đề là tích hợp DNA trong tế bào gan. Thành ra khi mà nó có cái sự tích hợp đó thì đó là nguồn cơn của cái viêm gan, xơ gan và ung thư gan. Thành ra khi chúng ta điều trị mà giảm được cái DNA thì chúng ta sẽ giảm được cái nguy cơ của ung thư gan. Thành ra giáo sư nói rằng là chúng ta sẽ điều trị hết tất cả những người có ADN dương tính. Và trong tương lai sắp tới thì mình cũng dẹp bỏ những cái guideline nó phiền phức tạp quá, nó nhiều cái chỉ định quá, nhưng mà chỉ cần ADN dương là chúng ta điều trị. Dạ, có câu hỏi. I have a question for you, Professor Gis. Follow all your opinion. In Vietnam, many patients in children, we can begin treatment for all patients at the age very early. Do you think about that?
Dr. C3, your question is about treating students or treating young adults?
Children, maybe children aged 5 and 10 years old.
It's a great question. The majority of hepatitis B in Vietnam is mother-to-child transmission. And we do have data using tenofovir and entecavir, including a label down to age 3. I'm not a pediatric hepatologist, but I think these precepts do apply to children as well, but we probably need more data for those under age 18.
Thầy Kính có ý kiến gì không? Vâng, xin mời giáo sư Kính.
Thank you so much, Professor Robekis. I think that's some guideline now. We focus in some guideline from the MOS. So we consider about your orientation, how to select the criteria for treatment. So we try to apply it in Vietnam, and many experts want to change maybe rapidly through some finding from your research and other guidelines from the ASEAN or ASEAN in Vietnam. Okay. So thank you so much for your participation and answer the question. Vâng, xin cảm ơn giáo sư Robekis, và bây giờ thì có lẽ không còn câu hỏi gì nữa. Thank you so much, Robekis. And hope that you will come to Vietnam and has some change your experience with the expert in Vietnam and how to guide building up the guideline for Vietnam simply and easy to use in health facility. Thank you. Vâng, và tiếp theo chương trình xin trân trọng giới thiệu và kính mời Phó Giáo sư Tiến sĩ Bùi Hữu Hoàng, trưởng khoa tiêu hóa Bệnh viện Đại học Y Dược Thành phố Hồ Chí Minh sẽ trình bày với hội thảo của chúng ta tiêu đề với một cái báo cáo với tiêu đề